Hey everyone. So this topic is about the liver and cirrhosis. Basically, what happens when you damage the liver and the consequences. But before we know the consequences, we really have to know, well, what does the liver do? There are a lot of functions to it. And instead of learning physiology, pathophysiology, biochemistry, pharmacology all separately, try bringing all of that together to understand questions. Because on the USMLE Step 1, they won't just give you a simple fact and ask you, oh, where is glycogen made? No, I mean they're never going to ask you that. They're never going to ask you where's glycogen stored. It's the liver, but that's too simple. They want to know if you can actually combine these concepts and actually apply them, not to reiterate facts. Okay. So the first thing, let's talk about the liver. What does it do? It stores glycogen, right? Now, what's glycogen if you haven't done biochemistry yet? It's basically glucose attached to one another, right? Chains of glucose. Now, and again, it's stored in the liver, right? Tons and tons of glycogen chains. When is glycogen used? When you're fasting, right? When you're fasting, what happens? The enzymes break down the glycogen into different glucose, easier basically glucose particles, which get released into your blood, which elevate your glucose levels while you're fasting. So it's kind of a buffer. It helps to maintain a certain level of glucose when you're fasting, right? So that's one of the functions. Okay. Second thing is proteins, right? All proteins, majoritively all proteins, are made in the liver, and again, this is including albumin, right? And what are some of the functions of albumin? Well, one of them is to maintain oncotic pressure, right? Which we talked about in the previous videos. Second function of albumin is to bind calcium, right? Okay. And what does that mean? That means that most of the calcium that's actually floating around in the blood is actually bound to albumin. However, this is the total calcium. This is different from ionized, okay? Ionized calcium is the calcium that's not bound to albumin. Ionized calcium is a calcium that actually plays a role in causing whatever reaction it causes. The calcium bound to albumin doesn't do anything. Okay, and another thing is it binds drugs, right? A lot of drugs that come into your system are bound to albumin. Okay, and different proteins. Another protein we think of is our clotting factors, right? Okay, these include 2, 7, 9, 10, all protein C, protein S. All of the clotting factors are actually made in the liver, except which one? 8, right? Where is 8 produced? In the endothelium, right? Okay, other thing, what does the liver also do? The P450 system, right? Detoxifying drugs. Okay, that's one of the biggest things that the liver does is all of the blood and all the drugs that are coming through your oral GI system get absorbed through the superior and inferior mesenteric veins. Remember we went over this anatomy. Where did they go? They go up through the portal vein into the liver, and in the hepatocytes here are majoritively the P450 system, and this P450 system metabolizes and breaks down a lot of these drugs, because when these drugs are introduced to your system and your liver senses them as foreign. And any foreign particle, it'll treat just like a bacteria, it'll treat just like a toxin and say, hey, my body didn't produce this, I need to get rid of it. So it metabolizes it immediately, okay? What's another thing? Now this is something else that's actually on the USMLE a lot, and that it metabolizes estrogen. Right? Okay, and I'll actually talk about like some clinical significance with this, right? So a lot of the estrogen that's actually produced, now again, where is it produced? Adipose cells, right? And what enzyme produces it? Aromatase, right? So what happens? This estrogen is floating around in your blood, does whatever it has to do, but where is it metabolized? Where is it broken down? In the liver, okay? Okay, now, let's see. One of the other biggest things here is the urea cycle, right? This is really, really big on the USMLE Step 1. A lot of questions. You'll see a lot of questions where they'll actually give you the urea cycle and they'll ask something about it or something relating to it, okay? Now, what is the urea cycle? Well, let's talk about first ammonia, right? Urea cycle is the way ammonia is excreted and sent out of your body. Okay. Now, where does ammonia come from? Where is it produced? Well, this kind of looks familiar to you, doesn't it? It's from amino acids. Right? Remember that NH group on if you look at any amino acid, you'll see an ammonia group there, NH3 group. Okay, and when this ammonia builds up, your body has nothing else to do with it, so it has to get rid of it somehow. And one of the biggest ways is the urea cycle. What's the second way it gets rid of ammonia? Through the renal system, right? The kidneys, in the urine, right? Okay, in the urine, because that way, how does it get rid of it in the urine? It turns NH3 into NH4. Why does it do that? Because when it turns into NH4, it becomes trapped. Okay, it becomes trapped because of its ionization, right? Into the ureter. And once it's NH4, it cannot be reabsorbed. I'll explain more of this in the nephrology section, but this is just a side excerpt. Now, getting back now to ammonia. In the urea cycle, ammonia is combined to make urea. And this all happens in the liver, okay? And what happens? Urea then goes to your kidneys and gets excreted that way, okay? By ammonia. By urea, I mean. Okay. Okay, now that we talked about all the things that the liver does, let's make it useful. Let's talk about some clinical applications, and especially with questions with the USMLE. Now, the first thing we talked about was glycogen, right? One of the functions of the liver is to store glycogen. Now, if a patient has a disease which damages the liver, let's name some, liver cirrhosis, right? Due to what? Alcohol, right? Chronic alcohol abuse will lead to liver cirrhosis. Why? Because alcohol is metabolized in the liver, right? Every time an alcoholic drinks alcohol, it has to metabolize and it damages the liver. If it damages the liver, what's going to happen? Well, the same thing that happens if I cut your finger. If I cut your finger, what's your finger going to try to do? Heal itself, right? How does it heal itself? It forms a scab. And it's the same thing in the liver. The liver, every time it gets damaged, every hepatocyte that's damaged, it tries healing itself and forms collagen all around it. And other proteins to try to heal it. It's always trying to heal it, and by doing that, it's causing fibrosis, right? So that's one of the big things. Chronic hepatitis, right? It's one of the big things that can cause, chronic damage to the liver. And you have, all these other drug toxicities, all this chemotherapy drugs, etc. All can cause damage to the liver, right? So now, getting back to glycogen, if I have a patient, a 40-year-old male with chronic alcohol abuse, etc., and he comes in with a blood glucose of, 50, why? Why is that? It's because, well, number one, he's malnourished. He's probably not eating because he's drinking alcohol. The second thing is because he's depleting his glycogen stores. An alcoholic their glycogen stores will be really, really low in their liver, and they won't have that glycogen to use when they're fasting. Okay. And that's why they're really susceptible to that. Another USMLE question, just thinking, randomly, is if they show you two slides. And they say, okay, well, these are hepatocytes in the slides. Okay, slide 1 is from a healthy 35-year-old male. Okay, and slide 2 is from a certain patient. Now, then they say these black dots here are glycogen. Then they ask you, what type of patient does this slide represent? And then they give you options A, B, C, D. Well, you think of, well, where's glycogen stored? In hepatocytes. And this patient doesn't have any glycogen in their hepatocytes. What kind of patient would that be? Well, one of these alcoholic patients, someone with cirrhosis, fibrosis, who does not have the ability to store glycogen, right? And of course, there are all of those other glycogen storage diseases, but that's just one example of how you have to take these facts and actually apply them to concepts, okay? And you make questions as you go. Think about questions as you learn these different concepts and facts. Okay, now let's talk about proteins and albumin. Cirrhotic patients, you ever notice they have edema? Yeah, right? Because of low oncotic pressure. They don't have the albumin in, they can't produce the albumin in their blood, in their liver to send to their blood to cause any oncotic pressure. So can the water and the plasma stay inside the blood vessel? No, the water leaves the blood vessel, right? And that's why it's low oncotic pressure. They develop that edema around their belly, the massive ascites, and they always have to get paracentesis done, right? And they take out liters and liters of fluid. Okay, one of the big reasons. And any USMLE question, if they ask you, okay, well, and they give you a clinical exam finding, they show you a picture of a patient with ascites and ask you, and give you some history. Oh, this is a 40-year-old male with a chronic history of, alcohol abuse, etc., etc. Show you a picture of massive ascites in the belly, then ask you, what is the pathophysiology behind it? It would be low oncotic pressure due to little to no albumin being produced, and actually an increase in hydrostatic pressure because of the backup of the portal vein. But it's unlikely that they would give you both of the answers, and ask you to choose one. Let's talk about calcium now. Right? We talked about calcium. If the patient has cirrhosis and they're not producing any albumin, they can't bind calcium. So what's going to happen to my total calcium level in the blood? Probably be low, right? Because there's no albumin to hold it. However, what will happen to my ionized calcium? It would actually stay the same. It wouldn't be affected, okay? And this is actually a concept which I'll talk about in a separate video, but ionized calcium does not change. It stays the same to have the same amount of level in your blood, because a big change in your ionized calcium level will cause a lot of symptoms, like if you become hypocalcemic, it'll cause tetany, etc. Okay, drugs, right? It binds a lot of drugs, albumin. So if albumin's not there, it can't bind drugs. What is it going to do? Either cause toxicities, etc., etc. Right? One of the other things. Let's go move on now. Clotting factors, right? All the clotting factors, like I said before, are produced in the liver. So if I have a patient with cirrhosis, can they produce clotting factors? No, they can't produce any of these clotting factors. So what's going to happen? If they can't produce clotting factors, can they clot blood? No, they can't. So what do? They tend to bleed, right? They tend to bleed. So when I have that 45-year-old alcoholic male and they tell you that he's bleeding, he has these signs and symptoms, why? Because of this reasoning, because they can't make clotting factors in their liver, right? Make sense? Now let's go on now. P450 system, detoxification, metabolizing drugs, right? So if I tell you, let's say drug A was given to a patient and they noticed that really, really high levels in the blood, why? As opposed to another patient, B. Well, because maybe patient A doesn't have a P450 system. It can't detoxify, it can't metabolize the drugs, meaning that that the liver is really responsible for making sure the drug levels aren't high in your body. Okay, so if in cirrhotic patients, this is why you're really, really careful about giving drugs that are metabolized by the liver, because if they are, you are going to cause toxicities. Okay. Toxicities with these drugs if they are cirrhotic, okay, because they can't metabolize it. Make sense? Metabolizing estrogen. Now, I talked about this before, right? You ever notice cirrhotic patients have, number one, gynecomastia? And what's the other clinical exam finding on their chest? Spider angiomas, right? Why? Why do they have this? Well, you have your answer right here. If the patient's cirrhotic, can they metabolize estrogen? No, they cannot metabolize estrogen. So what happens? Their estrogen level rises. Any typical, just making up a USMLE Step 1 question, they give you patients A, B, C, D, and show you different varying, estrogen levels, et cetera, and ask you, oh, which one of these would you expect a patient with cirrhosis to have? You'd obviously pick a higher one. Now, again, this is just an example, but just think of ways you can apply this fact into a concept, especially like a graph-like concept. Okay. Again, that's why they have gynecomastia, because of increased estrogen. Spider angiomas. These are, the small, vessel-like shaped things on the patient's chest. What are they? Blood vessels, right? Why are they so prominent? Because what does estrogen do? Vasodilates, right? It vasodilates. That's why they become more prominent and you can see them. There's so many questions on USMLE Step 1 where they actually show you a picture of a patient with a spider angioma and ask you, oh, what's the, they can either ask you one, what's the pathophysiology? What's the physiology behind it? You'd have to say, the estrogen. They might ask you, they can ask you really anything about it. Okay, now let's move on now to the urea cycle, right? We mentioned this before. This is where the urea cycle takes place. This is how ammonia is excreted and gotten rid of from your body. Now, if I don't have my urea cycle, can I make urea? No, I cannot, right? I can't make urea. So what happens to my ammonia level in the blood? It'll increase, right? It'll increase. And what will that cause? Hyperammonemia. All that means is just a really high ammonia level, right? And what does a really high ammonia level do? Causes altered mental status. So that's why patients with cirrhosis come in confused, lethargic, delirious, all these things because of high ammonia levels. You always check an ammonia level in a patient with cirrhosis, right? Okay, now again, what do we say? Where is ammonia produced? Well, from amino acids. Where do amino acids come from? Proteins, right? Okay, and we eat proteins a lot. All the meats, every food we eat has protein in it. That's why we tell patients with cirrhosis to go on a low protein diet. Why? Because we know they have cirrhosis. We know they can't turn ammonia into urea. So if we give them protein, it'll just cause a really high level of ammonia, and that'll cause hyperammonemia. So that's why we reduce the amount of protein they get, reduce the amino acids. That way they cannot have, that'll have a lower chance of getting hyperammonemia and altered mental status. Okay. The second thing is, what's the other drug we give to cirrhotic patients who have hyperammonemia? Lactulose, right? What does that drug do? It decreases the absorption of amino acids. Okay. I won't go into the exact mechanism here. But it decreases the absorption of the amine, okay, amino acids, and that way, again, lower risk of developing hyperammonemia. Okay, makes sense? If you have any questions, feel free to post them underneath this video. Thanks.